What is minimally invasive surgery? A question that a lot of patients ask me. Are you doing my surgery robotically? Are you using the robot? Are you doing it laparoscopically? And some, very rare, but some patients will come to me and say, I want my surgery open. I don't trust the small incisions. A lot of funny stories. I'll probably, as I go through this journey, I'll be posting them little by little of examples of the patients, but I'll focus on what is minimally invasive. So, as I mentioned in my previous video, uh, the old traditional way from 100 years ago was to cut open the patient. This Fannin steel, which is sideways, or midline, which is upside down, or zip line, I call it, um, to to go into the abdomen, to expose the anatomy, and to do the hysterectomy, because they didn't know anything better. A guy somewhere practiced on something. There was always that first hysterectomy, and surprisingly, almost 100 years later, almost, we are still doing the open hysterectomy using the same tools and the same technique. So it's kind of mind blowing in a way, because in any other industry, whether it is in technology or innovation or anything, pharmaceutical, everything, anything, they advanced like you can't even compare the advancement from the beginning of that innovation. But for in medicine, we don't advance as fast as other industries. Uh, there are many reasons. My theory is patient safety, regulation, fear of being sued, fear of being judged, many other factors. So you stick with what you know because you don't know what you don't know. Luckily enough, in the 80s, someone was brave enough to say, I can look, because they started kind of using the scope, or you looking through a little camera using candles. There was a cystoscopy, there was a hysteroscopy, which is looking through the uterus. So other part of the body, other physicians started looking with little cameras. So Dr. Harrich said, you know what, in the United States, at least what I know is, let me try our first hysterectomy. So they went in successfully, but you can just imagine from the 80s to now the advancement in the tools we have to do the laparoscopic surgery. Not an open. Open is exactly the same tools, the same everything, but for minimally invasive, for laparoscopy, we are using the principles. Anatomy is anatomy, it's the same, but our cameras are better, lighting is better, our instruments is better, energy devices is better. What's the difference? Why did they not start laparoscopy from 100 years ago? Because there was no technology, there was no gas insufflation, there was no energy devices. They barely had a light, probably, or not. I have to check my information, but you can just imagine that they needed to manually open the abdomen, be inside the abdomen, and use tools to actually, like a big forceps, big metal giant forceps, to put around the blood vessels, because each organ, we're alive, we're full of blood and blood supply, and each organ, especially the uterus, the ovaries, will have blood. So you can't just chop it and leave it just like that, because then the patient will bleed to death. So you need to ligate the blood vessel, which is kind of compressing it, and somehow cut it and then suture it. That was the open hysterectomy technique. So ligate, cut, suture. And they didn't have anything better, so they did it the how you imagine it, imagining doing it with, I don't know, like just the idea of it, right? Basic. So they did that, and they carried on for years and years and years until the 80s, when they had some, they started the discussion every now and then about laparoscopy, about looking inside the abdomen, about a camera technology, about gas technology that you can expand the abdomen. Because if you're not opening the patient, if you're opening the patient, you can just use retractors, which is a device to pull the abdominal wall aside. So you're having, you kind of visualize inside the patient's abdomen. But laparoscopy, you're using tiny incisions, and if the abdomen is flat, because there's negative energy inside the abdomen. There's no free air inside the abdomen. It's negative energy. So if it's negative and there's no air, we can't see anything because there are other competing organs in the abdomen: bowel, bladder, liver, many other organs in the abdomen. So to reach the uterus, which is deep down the pelvic area, and usually small, you really need to be able to see it, to reach it and see it. So the technology was to put through those incisions to put CO2 gas. It distends the abdomen. It becomes distended like this, and then you go in through with the camera. Then you created a space now, and you can see. And with the lighting of the camera, it becomes like a from a dark room to a lit up room. And then obviously because of the location of the uterus down in the pelvic area, if the patient is flat on the table, you won't be able to see the uterus. So in our cases, usually we put the patient in Trendelenburg position, head, legs. And the legs usually spread because we usually put a device through the uterus, a cervix to the uterus to help us move the uterus. We call it uterine manipulator, which is a device that helps us move the uterus. And that helps a lot because once you're in, patient is head down, Trendelenburg position to the maximum that the table operate. The operative table moves electronically. So we ask the anesthesiologist after we put the ports, we're looking, and then automatically you'll see the bowel sliding up toward the upper abdominal cavity. And if the patient's BMI is not big and no other restrictions, no restricted pathology like previous surgery, scarring, or lesion, then you will right away see the uterus. You can see it on my YouTube channel, cases about the hysterectomy and what the uterus look like, and I'll be posting as well. Then you have exposure, you have lighting, you have room to operate. Now you need tools, and you usually need 3 to 4 ports. I usually do 4 ports, but if someone needed additional hands, there's no limit of how many ports the patient has. The ports is the 5 millimeter or 10 millimeter incision. And then you put it's like a straw-like instrument. We call it trocar, and then through that with the valve so that air doesn't leak. Then you put other instruments through that straw-like instruments, the trocar, to be able to operate through looking at a monitor, at a camera. So, because you can look inside the abdomen is closed with little holes that you can't see through them. So you're just going to use those instruments and look through a monitor. It's a process that needs a learning curve, so it gets some time to kind of get used to that, and the learning curve is long with laparoscopy. And then you obviously do the same, but you don't need, because we're using advanced technology, you don't need the ligate, cut, and tie that was more manual with using instruments, knife, and sutures. We got rid of that laparoscopically. We use energy devices. Energy devices that once I'll show it to you in another video. You go in, clip, and then apply the energy, zip, and it zaps, which is kind of cauterizing, and then it kind of agglutinate the tissue or make the tissue adhere. And then there's another trigger button you press, and it separates. So it coagulate and cut at the same time, not at the same time, one after another. And then you'll see the pedicle opening, and then you continue doing pedicle after another until that organ is free. Then you deliver that organ. If we're doing a hysterectomy, the best opening is from down below through her vagina. If you're not doing a hysterectomy, then different ways, and I can post them later. Obviously, when we perform the surgery, when we're done and we take the pathology out, we have to. If we're not suspecting cancer, we just send it for permanent pathology. If we're suspecting cancer, we send it for what we call a frozen section, which I do all the time. And frozen section is a quick pathology. Like they don't have enough time to stain the tissue and cut it appropriately to look at the entire specimen and to stain it with all the stainings that sometimes take a few days. They do a quick staining, takes about 10 to 15 minutes, and it's 80 to 90% accurate. It's accurate enough for us to know to proceed with doing cancer staging surgery or just end the case. And that's another video. Then we reconstruct, we make sure that we irrigate with water or normal saline, we clean up, we make sure also we lower the pressure, we make sure there's no bleeding, and when everything is clean and looking good, then we deflate the abdomen, let the gas go out, take the trocars, close the incisions, and the patient is good to go. Then any pathology we take out of the patient is sent to pathology. And then when I see the patient post-operatively, then we have that pathology report and we discuss what was the pathology. Hopefully it's benign. If it's benign, most of the time we do surgery for a reason, pain or a mass or abnormal bleeding. So the pathology will come back saying benign versus malignant. And if it's benign, was it endometriosis? Was it fibroids? Was it just benign cysts? And there are many topics that I'm going to talk about. But once it's benign, patient's doing well. We make sure that we review everything with the patient. And most of the patients, when you do the minimally invasive, it takes about 2 weeks for them to recover and go back to work. Very rarely we have to extend another week, but the patients don't need any more than that. I'll talk about recovery in a separate video. You can see a lot of videos are coming, so stay tuned and follow if you would like. And if we are doing the same surgery robotically, which is an amazing tool to help surgeons do the procedure, especially if they're not laparoscopically trained. Again, you remember me saying laparoscopic surgery is very challenging to learn. It takes a longer learning curve. So you have to dedicate years of training to become a good laparoscopic surgeon, and thousands of patients after that to become competent laparoscopic surgeon. But with the robot, it's an amazing device that took a lot of those challenges away. With the laparoscope, you're working with rigid instruments where you're working with a 2D image, so the depth of perception is not clear if you're not an expert surgeon. And then you don't have rotating tips at the instruments. So if you're suturing, it's all like in and out or horizontal kind of move. Obviously, when you reach an expert level like myself, all those challenges dissolve just because you got better at understanding what to do, the tips and tricks. It takes years and years and years. I teach my fellows laparoscopic skills. Unfortunately, because of the challenge and because of the robot, that the laparoscope is not growing. I hope it's not dying, but it's not growing because there is a technology, especially in the United States, that could compromise for that and do it in an easier way for a surgeon that is not used to do laparoscopy or don't have enough cases or don't have enough training. For the patients, it's the same result as laparoscopy. There's no difference. Outcome, no matter what they tell you, I love the robot, I love the scope, the outcome is the same. The outcome is the same for the patient. For the surgeon, if they're not comfortable with the scope, the robot will make their life a lot easier, because the visualization is 3D, so its precision is beautiful. All the instrument has articulation, they move in all directions, so it's almost similar to your hand outside of the patient, as if you're doing something open. And the instruments are brilliant as well. And you don't have to scrub. You saw some of my videos. Once you put the ports, you connect the main instruments on the patient. There is always an assist and a scrub nurse, but then the surgeon can go and sit on the console and use a little tiny tool to operate on the patient remotely. The idea of it, when they started it, is to operate in the battlefield with thousands of miles different. I don't think that idea picked. Maybe it does exist. I'm sure it does, but it's not commonly used or known. But our robot, our console is in the same room. So we're constantly with microphones, with everything, with monitors, like you saw in some of my videos. So we're constantly communicating, and I can always go back and forth between to checking on the patient if I need to check anything. Timing wise, if you are not a good, not well trained laparoscopic surgeon, obviously you're going to do it a lot faster with a robot. Common sense. And you can learn a lot faster. You can acquire the skills of reaching an efficiency level that is excellent in a smaller number of cases. So overall, the surgeon, it will help the surgeon that is not well trained laparoscopically to achieve great results for the patient. That's why I am a pro robot if you need it. And I also operate on the robot because it's cool to operate, especially in difficult cases. And if I get to sit just as a variety. And the main thing for me is for the ability for me to teach others. Because no matter how good I am laparoscopically, I can teach my fellows because they're with me for 2 years. But then I can't teach another gynecologist that I'm visiting or mentoring, which I've done a lot in the past. I can go to the OR, watch them, tell them it's impossible. It's impossible. But with the robot, in a case or two, or a day or two, depending on how experienced they are, I can actually uh, reproduce my knowledge and kind of improve their skills significantly. And because I'm an educator and I'm a teacher, and my purpose is to elevate women's health, patients' care, I am a pro robot if it's going to make you a better surgeon and a safer surgeon and achieving great results for your patients. That's in summary, and we'll talk a little more about different subjects in my next.